You're standing in the grocery store and something shifts. A brief sense that the floor isn't quite level. A fraction of a second where your balance doesn't feel like your own. You grab the cart handle. It passes. You tell yourself you're tired. You tell yourself it was nothing. And you move on. I need you to stop for a moment and take that symptom seriously. Because a brief episode of unexplained unsteadiness or dizziness in a middle-aged or older adult is not nothing. It is one of the most under-recognized warning signs in clinical medicine, and in a meaningful percentage of cases, it is a signal that the brain's blood supply is being compromised, transiently, intermittently, but in a way that can precede a full ischemic stroke by hours, days, or weeks. A transient ischemic attack, what clinicians call a TIA, what the public often calls a mini stroke, produces symptoms that resolve completely within 24 hours, usually within minutes. That transience is exactly what makes it dangerous, because it convinces people that nothing happened, that they don't need to go to the emergency department, that they can wait and see if it happens again. The evidence says something very different. The ABC-D2 score, a validated clinical risk assessment tool used in emergency medicine worldwide, shows that in the 48 hours following a TIA, the risk of a full stroke can be as high as 10 to 15% in high-risk patients. 10 to 15% in 48 hours. That is not a wait-and-see situation. That is a medical emergency. So let me be direct with you about what this video is and what it isn't. This is not a video designed to frighten you into unnecessary medical consultations. This is a video designed to give you the clinical literacy to recognize a genuine warning sign when it's happening, and to understand the physiological mechanism well enough that you don't dismiss it as fatigue or aging. Because the dismissal is where lives are lost. Not in the hospital, not in the ambulance, in the grocery store when someone grabs the cart handle and thinks nothing of it. If this is the kind of clinical depth you want, subscribe to this channel. We're building toward 100,000 subscribers. People who want real information without alarm and without oversimplification. Let's keep building that together. I want to tell you about a patient I'll call Harold. He was 71. He came in for a routine follow-up. Hypertension, type 2 diabetes, well managed on medications, doing reasonably well. Almost as an afterthought at the end of the visit, he mentioned that about a week prior he'd had a moment of feeling off balance, and that his right hand had felt strange. Not numb exactly, but not quite right, for maybe 10 minutes. Then it passed. He figured it was because he'd been working in the garden and overheated slightly. He didn't think it was worth mentioning. He mentioned it as an afterthought. That afterthought sent him directly to the emergency department. Imaging revealed a small area of restricted diffusion in the left posterior internal capsule, consistent with an acute ischemic event. He'd had a TIA. And the follow-up workup found a significant stenosis in his left middle cerebral artery territory. He was started on dual antiplatelet therapy, his statin was intensified, his blood pressure management was tightened, and he was referred for a vascular neurology consultation. 1 year later, Harold had not had a stroke. But had he not mentioned that 10-minute episode, had he waited another week or another month, the outcome might have been very different. What saved Harold was not the treatment. What saved Harold was that he mentioned an afterthought. I want you to understand what the afterthought means so you never dismiss it. Here's how to understand what's happening physiologically when the brain's blood supply is briefly interrupted. Because once you understand the mechanism, you understand why the symptoms look the way they do and why they're so easy to miss. Think of the brain as the most power-hungry organ in the body, which it is. The brain represents roughly 2% of total body weight, but consumes approximately 20% of the body's total oxygen supply and about 25% of total glucose. It runs on a continuous, non-negotiable supply. There is no oxygen reserve in neurons the way there is in muscle tissue. When blood flow to a region of the brain drops below a critical threshold, even for seconds, neurons in that region begin to behave abnormally. If the drop in flow is brief and partial, the neurons recover when flow is restored. That's a TIA. If the drop is sustained long enough, neurons die. that's a stroke. The biological transition between those two outcomes happens in minutes. And the symptoms that each brain region produces when flow drops are specific to that region's function. The posterior circulation, the vertebro-basilar system, supplies the brainstem, cerebellum, and occipital lobe. Disruption here produces dizziness, balance problems, visual disturbances, and double vision. The anterior circulation, the carotid system, supplies the frontal lobe, parietal lobe, and motor and sensory cortex. Disruption here produces weakness, numbness, speech difficulty, and facial drooping. This is why the symptom pattern of a TIA tells you something specific about which vessel is compromised. And this is why unsteadiness is not a generic complaint. It is a specific neurological signal. Sign 1. Sudden unexplained unsteadiness or balance failure. The clinical term is sudden onset ataxia, an acute disruption of coordination that was not present moments before. The key word is sudden. Chronic progressive unsteadiness, the kind that gradually worsens over months and years, is a different clinical entity, most often related to peripheral vestibular dysfunction, cerebellar degeneration, or sensory loss in the feet and legs. What we're talking about here is the acute, sudden onset of imbalance with no clear environmental cause. You weren't dizzy from standing up too fast. You weren't dehydrated in the heat. You were simply walking and suddenly felt that your coordination wasn't working. This can feel like vertigo, a spinning sensation, or simply like the floor is unreliable, like you cannot trust your proprioception. In vertebro-basilar TIAs, the cerebellum, the brain's primary coordinator of smooth movement, is typically in the affected territory. Cerebellar dysfunction produces a very specific kind of unsteadiness, gait ataxia, where the walking pattern becomes wide-based and lurching, and limb ataxia, where reaching for an object produces an overshoot or tremor-like inaccuracy. If you have had a brief episode where your walking felt wrong or where you misjudged a reach and couldn't understand why, that is a neurological symptom. That needs evaluation. Sign 2. Transient visual disturbance. The window you cannot afford to ignore. The eye is, neurologically speaking, an extension of the brain. The retina is neural tissue. The optic nerve is a tract of the central nervous system, and the visual cortex, located in the occipital lobe at the back of the brain, is supplied by the posterior circulation. Transient visual symptoms associated with TIA take several forms. Amaurosis fugax, temporary monocular blindness, often described as a gray or black curtain descending over one eye, is caused by brief occlusion of the ophthalmic artery, which is a branch of the internal carotid. It typically lasts seconds to minutes and resolves completely. This is one of the most specific warning signs of carotid artery disease and carries a high risk of subsequent stroke. Binocular visual disturbance, affecting both eyes simultaneously, is more often associated with posterior circulation TIA and may involve blurring, dimming, visual field loss, or a shimmering visual disturbance called a scintillating scotoma. This is distinct from the aura of migraine, though the two can be clinically difficult to differentiate without careful history. Any transient, unexplained change in vision, especially if it occurred alongside other neurological symptoms, however brief, requires same-day medical evaluation. The American Stroke Association guidelines are unambiguous on this point. Transient visual symptoms with a possible vascular etiology are treated as TIA until proven otherwise. I want to pause here and ask you to drop your age in the comments, because the risk profile for cerebrovascular disease shifts significantly with age, and I want to be specific rather than generic. Here's why age matters so precisely for this topic. The Framingham Heart Study, one of the longest-running cardiovascular epidemiology studies in medical history, established that stroke risk roughly doubles with every decade of life after 55. The mechanisms behind this include progressive arterial stiffening, which raises pulse pressure and increases endothelial shear stress. They include the accumulation of atherosclerotic plaque in the carotid arteries and the circle of Willis. They include the increased prevalence of atrial fibrillation, which is the most common cause of cardioembolic stroke, where clots form in a fibrillating left atrium and travel to the brain. And they include the increased likelihood that hypertension, diabetes, and dyslipidemia, the three major modifiable risk factors for stroke, have been present for years and have caused cumulative vascular damage. Before 55, a transient episode of unsteadiness is worth investigating, but is more often explained by vestibular dysfunction, migraine, or orthostatic hypotension. After 55, and especially after 70, the prior probability that a transient neurological symptom represents cerebrovascular disease rises substantially. Your age tells me how urgently I would want you evaluated. Drop it below. Sign 3. Sudden speech difficulty. The symptom people are most likely to rationalize away. Aphasia, disruption of the language system, is one of the most specific and alarming symptoms of anterior circulation TIA. But the transient form is subtle enough that people consistently explain it away. What does transient aphasia look like? You are speaking and suddenly the word you want is simply gone. Not a tip of the tongue sensation. This is different. The word is genuinely inaccessible. You may substitute the wrong word without realizing it. Your sentence structure may become simplified or disorganized. Someone listening to you may notice that your speech doesn't quite make sense, while you feel that you're speaking normally. This is the expressive aphasia of left hemisphere dysfunction. It can also present as sudden difficulty understanding language, words being spoken to you that seem suddenly foreign or garbled. This is receptive aphasia. In both cases, the language system in the dominant hemisphere, almost always the left hemisphere, even in most left-handed people, is experiencing insufficient blood flow. And in the transient form, this resolves within minutes to hours and leaves the person convinced that they were simply confused or tired or distracted. They were not confused, they were experiencing a neurological emergency. If this has happened to you, even once, even briefly, even if it fully resolved, you need to say exactly that to a physician, in those words, and you need that conversation to happen soon. Sign 4. Unilateral weakness or numbness, the half-body signal. The motor and sensory cortex of the brain are organized in a contralateral pattern, meaning the left hemisphere controls the right side of the body and vice versa. When an ischemic event affects the motor or sensory cortex, or the internal capsule through which those fibers travel, the result is weakness or numbness affecting one side of the body, the face, arm, and leg on the opposite side from the affected hemisphere. In the transient form, this might feel like a sudden heaviness or clumsiness in one arm, a foot that doesn't lift properly for a few minutes, a facial droop that you notice in the mirror but that's gone an hour later, a patch of numbness or tingling on one side of the face or one hand that has no explanation and resolves on its own. What distinguishes this from the common pins and needles of a compressed nerve is the sudden onset and the hemibody distribution. One whole side of the body affected simultaneously, not a local compression pattern. Carpal tunnel syndrome causes numbness in the hand. A cervical disc causes numbness in the arm in a dermatomal pattern. Hemispheric ischemia causes numbness across the face, arm, and leg on the same side simultaneously. The pattern is different. Once you know it, it is recognizable. And it is never something to rationalize or postpone evaluating. Sign 5. A sudden severe headache, the one you've never had before. This sign is different from the others because it applies primarily to hemorrhagic events rather than ischemic ones, specifically to subarachnoid hemorrhage, which occurs when a cerebral aneurysm ruptures and blood floods the space around the brain. The clinical descriptor is thunderclap headache, a headache of maximum or near maximum intensity that is reached within 60 seconds of onset, as opposed to the gradual crescendo of a tension headache or even a migraine. Patients consistently describe it as the worst headache of my life, and that specific phrase in that specific context should be treated as a medical emergency until proven otherwise. The British Medical Journal and multiple Neurology Society guidelines specifically cite that presentation as one requiring urgent CT imaging and lumbar puncture if CT is negative. This is not a wait-and-see symptom. This is a call emergency services symptom. Not every sudden severe headache is a subarachnoid hemorrhage. Many have benign explanations. But the ones that are subarachnoid hemorrhage have a mortality rate of 30 to 40% even with treatment, and the initial survival window depends entirely on how quickly imaging and intervention begin. Here is the prevention protocol, the specific, evidence-grounded steps that reduce stroke risk meaningfully and that you can begin today without a prescription. Step 1. Know your blood pressure and treat it aggressively if it's elevated. Hypertension is the single most important modifiable risk factor for stroke. The SPRINT trial, published in the New England Journal of Medicine, found that targeting a systolic blood pressure below 120 rather than the conventional target of below 140 reduced the rate of major cardiovascular events, including stroke, by 25%. At-home blood pressure monitoring, twice daily, with a validated upper arm cuff device is the standard of care for hypertension management. Know your numbers. Step 2. If you have atrial fibrillation, make sure you are on anticoagulation unless there is a specific contraindication. Atrial fibrillation increases stroke risk by approximately 5-fold. Modern direct oral anticoagulants, rivaroxaban, apixaban, dabigatran, have been shown in large randomized trials to reduce atrial fibrillation-related stroke risk by 60 to 70% compared to no treatment. This is one of the highest value interventions in all of cardiovascular medicine. Step 3. Exercise. 30 minutes of moderate aerobic exercise 5 days per week reduces stroke risk by up to 27%, according to data published in Stroke, the Journal of the American Heart Association. The mechanism is multifactorial: blood pressure reduction, improved endothelial function, reduction in inflammatory markers, better glucose control, and improved cardiac output. Step 4. The Mediterranean dietary pattern, rich in olive oil, vegetables, fish, nuts, and legumes, has been shown in the PREDIMED trial, a large randomized study from Spain, to reduce the rate of major cardiovascular events, including stroke, by approximately 30% compared to a low-fat diet. This is not a fad diet. This is one of the best studied dietary patterns in cardiovascular medicine. The bottom line is this: your brain does not give you a second warning. A TIA is the first warning. The sudden unsteadiness in the grocery store. The word that went missing for 3 minutes. The visual curtain that descended and then lifted. These are not nothing. They are the most important clinical signals your vascular system will ever send you. The FAST acronym: face drooping, arm weakness, speech difficulty, time to call emergency services, is a useful population-level tool, but it misses the subtler signs: the unsteadiness, the brief visual disturbance, the transient confusion. If you have experienced any of the signs I've described today, even once, even briefly, even if it resolved completely, please discuss it with a physician. Not next month, this week. The biology does not wait. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. Let me go deeper on the cardiovascular architecture of stroke risk, because understanding the underlying biology changes how seriously you take the modifiable factors. The brain receives its blood supply through 2 paired systems. Anteriorly, the internal carotid arteries bifurcate into the middle and anterior cerebral arteries, supplying the frontal, parietal, and lateral temporal lobes, the regions responsible for voluntary movement, sensation, language, and executive function. Posteriorly, the vertebral arteries unite to form the basilar artery, which supplies the brainstem and cerebellum before branching into the posterior cerebral arteries serving the occipital lobes and medial temporal structures. These 2 systems are connected at the base of the brain by the circle of Willis, a ring of communicating arteries designed to provide collateral flow if one vessel is compromised. In a healthy vascular system with a complete circle of Willis, occlusion of one vessel can be partially compensated by rerouting blood through the collateral channels. But in patients with widespread atherosclerosis, whose collateral vessels are also narrowed and stiff, this redundancy is lost. The circle of Willis, designed as a backup system, becomes as compromised as the primary vessels. This is why atherosclerosis is not a localized problem. It's a systemic vascular disease. When you have plaque in the coronary arteries, you have plaque in the carotid arteries. When you have carotid disease, you have vertebral artery disease. The risk is distributed, and the interventions that reduce risk, blood pressure control, lipid management, smoking cessation, anti-inflammatory nutrition, exercise, are systemic interventions that improve vascular health across the entire network. There is one more risk factor I want to address specifically because it is criminally underdiagnosed: sleep apnea. Obstructive sleep apnea causes intermittent nocturnal hypoxia, repeated episodes during sleep where breathing is obstructed, oxygen levels drop, and the brain is briefly deprived of adequate oxygen delivery. Each apnea episode triggers a stress response. Cortisol and catecholamines surge, blood pressure spikes, and the endothelial lining of blood vessels experiences oxidative and inflammatory stress. Over years, this causes endothelial dysfunction, accelerated atherosclerosis, and a significantly elevated risk of both ischemic stroke and cardiac arrhythmia, including atrial fibrillation. A large prospective cohort study published in the American Journal of Respiratory and Critical Care Medicine found that moderate to severe obstructive sleep apnea increased the risk of ischemic stroke by approximately twofold, independent of other stroke risk factors. And yet sleep apnea is underdiagnosed in the majority of people who have it, particularly in women, where the classic presentation of loud snoring is less common and the symptoms more often present as fatigue, morning headache, and mood disruption. If you snore, wake frequently, or feel unrested despite adequate time in bed, ask your physician about a sleep study. The treatment, CPAP therapy, has been shown in randomized trials to reduce blood pressure, reduce inflammatory markers, and in observational data to reduce stroke risk. It is not a small intervention for a minor problem. It is a major intervention for a major stroke risk factor that most people don't know they have. I want to close this section by returning to Harold, because his story doesn't end with the diagnosis. After Harold was stabilized, we sat down and went through every element of his cardiovascular risk profile. His blood pressure had been managed, but his home readings, which we started collecting twice daily, showed a pattern of early morning hypertension that his clinic readings had never captured. We tightened his medication. We reviewed his diet. We got him walking 30 minutes daily. We checked and treated his vitamin D deficiency. We identified that he had moderate sleep apnea and got him started on CPAP. And we educated him, clearly, directly, without alarm, about the specific symptoms that should send him to the emergency department immediately, without calling first, without waiting to see if it passes. Harold understood, perhaps for the first time, what his vascular health actually looked like, why it mattered, and what he had the power to change. That understanding is what I want to leave you with. Not fear, not helplessness, understanding. Because the difference between a stroke and a warning is often just the knowledge to take the warning seriously.